Okay, let's get started with this Chapter 1 podcast. If you look at the required textbook and start reading Chapter 1, you'll notice that it's 29 pages to read in that textbook. In this podcast, there are 29 slides. I'll try to get through these as quickly as possible. These podcasts are meant to be an introduction to the chapter, not a comprehensive discussion of the chapter. If you look through the chapter, at the beginning of the chapter, I should say, there are 16 learning objectives that are articulated here. And we'll go through those quickly as part of this podcast. The first thing I would mention is that there are some paradoxes with the U.S. healthcare system. I would say that basically on this one slide, number 7, we in this country have the highest expenditure per capita. We spend about 17% of the gross domestic product on healthcare. And yet, we have a lot of problems. There is fragmentation of the healthcare system. There's all different kinds of healthcare systems. Some people get caught in the cracks. There's a very high rate of medical errors. There are some disparities, and not everyone has adequate health insurance, even now with Obamacare. If you go back and look historically, which is a good part of this chapter, at the historical context for our healthcare system, it begins with a discussion of Galen's premise of humorism that was presented by Galen back in the 2nd century. And humorism, according to Galen, is the body is an interconnected whole with a natural balance. So even in 19th century America, they looked at Galen and felt like all healthcare should be driven by this particular premise, which is further articulated here by Charles Rosenberg. He went on, Charles Rosenberg, to talk about the use of drugs. Drugs had to be seen as adjusting the body's internal equilibrium. In addition, the drug's action had, if possible, to alter the visible products of the body's otherwise inscrutable internal state. Next in the chapter, they discuss 2 types of practitioners: the orthodox physicians, which you may know are the forerunners of our modern-day medical doctors. There were, and there still are in some countries, in even parts of our country, sectarians who offer folk medicine and homeopathy. There are different health values, therapeutics, and practitioners. In the past, a lot of this depended on who you were as a patient. If you were in the middle and upper classes, you often would seek out service in physicians' offices, drugstore, and cure establishments. If you were in the lower economic classes, you would usually go to these sectarians and seek out home remedies. The point being, even in the 19th century, people, when they did go to these physicians, they would get fee-for-service. There was no insurance involved. In the 19th to the 21st century, there were some changes, especially in the commercial manufacture of medicines, whereas they used to be made by druggists. Physicians dispense these proprietary medicines from their office, and pharmacists open stores to also sell these commercial preparations. In the latter 19th century, it's all the rise of these patent medicines, and they were advertised in newspapers and available in pharmacies. Around the turn of the centuries, reformers warned about the safety and fraudulent claims of patent medicines. They were labeled quacks. This was about the time in 1906 with the passage of the Pure Food and Drug Act. So now we're about halfway through this podcast. About halfway through the chapter, it switches perspectives to hospitals. Early in the 19th century, hospitals had origins in the almshouses for the poor and pest houses for isolation. You may know some about the founding of our college with St. Marguerite de Youville, moving from Montreal to Buffalo to start this indigent care for the poor. Early in the 20th century, physicians accepted the germ theory of disease over humorism. U.S. hospitals grew in number from 100 to more than 6,000 after World War II with funding from the federal government. And that's actually on the next chapter. Again, after World War II, the number of hospitals in this country skyrocketed, as was the founding of the National Institutes of Health and Medicare and medical education. Here are some highlights of hospitals in the last 2 centuries in our countries, especially focusing on things like Medicare and Medicaid, and also the friction between hospitals and society over cost and quality. Here's a slide on medicine. I want you to understand that changes in pharmacy education have followed in step with changes in medical education. So as medical education advanced, so did pharmacy. So again, more and more education over the years. Basically, you see some changes over the last century. In the 1970s, you see a new emphasis on social inequities, especially with the elderly. In the 1980s and 1990s, there's a focus on response to managed care. And in more recently, there's emphasis on patient-centered care models. So later in the semester, we'll talk about something called the medical home model that came about with Obamacare. Again, with pharmacy, that follows in step with advances in medical education. You see these where pharmacy education has gotten more and more required of pharmacists, especially in 1915 with the Flexner Report and the pharmacy struggle for professionalism. In 1975, which was just before I became a pharmacist, this concept of pharmaceutical care was advanced. You need to know this definition. Pharmacist accepts responsibility for drug use functions and provides those services governed by awareness of commitment to pharmacist interests. That's essentially a paraphrasing of what you're going to need to know later in the course. In 1990, there was a 6-year PharmD curriculum for all new students. Now with this new slide, there's a lot here, but what I really want you to get, and which you will probably see on the IRAT that you have to take, will be a question about the American Association of Colleges of Pharmacy. which established standards of education and practice in the United States. So again, you need to know the American Association of Colleges of Pharmacy, and that it established standards of education and practice in the United States. Although it is not here on this slide, you need to know it for the IRAT. Next, from beginning to end of the 20th century, there were a lot of factors that affected health. It comes as a surprise to most of my students that really public health has more of an impact on the health of the people in this country than pharmacists do. This is a question that you will see on the IRATs. Two major factors explaining the decline in infant mortality rates and an increase in the life expectancy that are generally cited are changes in the standard of living or lifestyle, including improvements in personal hygiene, diet, and housing, and also advances in public health measures. Again, much to the dismay of a lot of healthcare professionals, these are more important than progress in medical practices like with pharmacists, MDs, nurses, and so on. With the next slide, there are different hallmarks of the 20th century. Most of them revolve around regulation and funding. Again, I wouldn't put too much emphasis on this slide and these acts, as we will be discussing these through the rest of the course much more in detail. This is more of an introduction. The next slide, major hallmarks of the 20th century continued. There was the emergence in the early 20th century of prepaid health services, and you can see here in 1929 by Baylor University, 1938 by Kaiser Permanente out west, and in 1939 by Blue Shield. Health policy overview, public and private. Over the last century or so, there's been an increased dependence on third-party payments for medical care due to government policies. Remember, I mentioned at the very beginning of this podcast, a lot of people who could pay for physician services would pay it like a fee for service, essentially out of their pocket. This has been a big change. Employers have offered health insurance as a benefit to attract workers. They also get a tax deduction from it. And also back in 1965, Medicare and Medicaid were implemented to help Medicare for the elderly and Medicaid for the poor. Here on this slide, we talk about health policy, an overview. Basically, the big thing I want you to get out of this slide is that in 1973, there was the Health Maintenance Organization Act, and this caused the formation of what are called HMOs, Health Maintenance Organizations. I really want you to know for the IRAT that an HMO is a form of prepaid health coverage. That's what I really want you to get out of this slide. Now, there's other things that are important here, like 1996, the Health Insurance Portability and Accountability Act, HIPAA. Again, we'll talk more about that later in the course. 1997, the S-CHIP plan, and in 2003, Medicare Part D. On this next slide, I really want you to get into that Medicare Part D. Again, this will show up as a question on your IRAT. That Part D is the drug coverage portion of Medicare. Again, Part D is the drug coverage portion of Medicare. So there's been incremental healthcare reform by these different kinds of plans and acts, and then there is comprehensive healthcare reform that some people are considering, like, for example, a single-payer government-run program. Healthcare reform continued here. This last slide, I don't really want to get into it too much because a lot of this is still changing, but I do want you to get out of this the second bullet here, the Patient Protection and Affordable Care Act, often called Obamacare. That is the law of the land right now. I think the Republican-led Congress is trying to change that, but right now, that Patient Protection and Affordable Care Act, often called Obamacare, is still the law of the land. And with that is the end of this